So let's talk about diabetes and treatment. I know at the EMT level, the treatment is pretty easy, pretty straightforward. Kind of remind ourselves of some of those. But the assessment piece, in my opinion, is more important. So we'll kind of work through this one. Whoops. But we'll kind of, we're going to go back to kind of the anatomical, pathophysiological process of diabetes and what that looks like. And then we'll talk about the assessment and treatment of that. So obviously we're talking about is on the two sides of this, either the pancreas doesn't produce insulin or your body doesn't use the insulin properly. And that's kind of that type 1 or type 2 diabetes. It's interesting. I feel like we called it early onset diabetes. We called it juvenile diabetes. We called it type 1 diabetes. We called it type 2 diabetes. Now they're pretty much, most of the literature says they call it insulin dependent and non-insulin dependent. And how you see that is IDDM, which is insulin dependent diabetic, what is it, Mellitus, whatever it is. And then there's NIDDM is how you'll see it in a lot of literature of insulin dependent versus non-insulin dependent diabetics. Obviously, we're talking about the idea of our body using glucose, which is that sugar. It's required for energy and required for metabolism. It also is vital to our cellular life. So without that sugar, our cells can't survive like they're supposed to. Now the downfall of that glucose molecule is it won't transfer into the cell all on its own. It's too big. So it has to have insulin as that lock-in key that gets it out of the bloodstream and into our cells to be used for metabolism. And that's the whole purpose of insulin. Well, obviously, if your pancreas isn't producing the insulin, then your body can't transfer it out of your bloodstream into your cells, and it's not using energy. Or if your body's just not using the insulin specifically, it also can't make that transfer. What we're talking about, the insulin is produced by the pancreas and allows those large glucose molecules to pass into the cells. Depending on sugar intake and how much sugar and diet and balance and exercise and all those things all play an active role in this entire process. So this is kind of a look at like insulin, right? Eating a meal increases glucose levels, which causes the pancreas to release insulin, which signals the liver to begin taking up excess glucose and store it as glycogen, and then which causes a drop in glucose level to go back down to normal. Now that storing, what happens is we store that, and let's say you missed a meal or you haven't eaten or whatever, then your liver will kick in that storage and start throwing that in the bloodstream to help you out. Now, the nice thing about that, the glucagon and glucagon is at the advanced EMT level and the paramedic level, there is a drug called glucagon that can be given to a patient to help with that production of glucose. I really, really wish we could see the benefits of giving glucagon to EMTs, because your protocol for glucose is if they're conscious, they can have oral glucose. Well, how many of you know a diabetic who's hypoglycemic that's still conscious? Like usually we're presented with them unconscious. So we'll see if that drug ever makes its way. It's really easy. It's in a 1 milligram powder and a 1 milligram solution in a box together. And all you do is take the solution, stick it in the powder, you mix it up, you draw it up, put it, it's IM, it's an IM injection, and you inject it into the muscle, and it stimulates that liver to produce that life-saving glucose. Okay? So hopefully, one day, we'll see the benefit of that going to the EMT level. Again, that type 1 is the insulin-dependent diabetic, or IDDM. Usually they have to take a synthetic insulin prescribed as a supplement. We'll talk about the different delivery devices for that towards the end of the presentation. On the type 2 side, your body can't utilize the insulin properly, and so therefore, usually it's controlled by an oral medication, or they get on real strict diets, when to eat, when not to eat, plan it like you're supposed to. Take a look at their metabolism, take a look at their calorie intake. These were the dietitians and the what else they're called, diabetes educators who work with these patients and get them on a regimen that helps them and causes less issues. So let's talk about hypoglycemia, right, on the low side. Signs and symptoms, right, are what? What are our signs and symptoms? How do we know they're hypoglycemic? Don't say their sugar's low, because let's just take that out of there. Halting of consciousness.
Cold, shivering.
Okay, maybe cold and shivering. What's the respiratory rate? Usually. It's lower, right? Because if you think about it, anytime you impair the brain, breathing suffers. Toxins, drugs, alcohol, diabetes, stroke, head injury, see what I'm saying? Like anything that screws with your brain lowers your respiratory rate. Now, their heart rate is normally what? Normal to elevated because they're not breathing good, so their heart beats faster. But this doesn't impair cardiovascular system, so therefore you don't see cardiovascular components involved with this. Okay? Some of the causes: take too much insulin, doesn't eat, overexerts, overexercise, or they get sick, nausea, vomiting, not feeling good. Those all cause issues. Okay? Here's our signs and symptoms. The big dead giveaway with most of our hypoglycemic patients is the rapid onset. We're talking about minutes to 30 minutes, 20 minutes, something along those lines. Okay? It mimics some issues, right? It would not be uncommon. It was a lot more common a couple years ago. Law enforcement gets a call for a DUI. They show up, guy's driving the wrong way on the highway, he's swerving all over the place. Guy lights him up, flips his lights on, guy doesn't pull over, goes for a long time. Now the cop, he realizes the cop's there, he pulls over. Cop's like, what the heck? Guy's slurring his words, it's not making sense. Pulls him out of the car, he's stumbling around, gives him a field sobriety test, he fails. Cop's like, DUI. Throws him in handcuffs, throws him back in the cop car, takes him to the drunk tank, and what happens to him? Tips over and dies. And then they're like, ooh, that's not good. We need a lot of paperwork for this one, right? So now they're getting better of, we educated them. Listen, I get it, but what about taking their glucose, right? Coming out and making sure that's not the issue. So call us. We'll come out and check the glucose for you. It's not after 2 in the morning. Okay, pale, sweaty skin, tachycardic, rapid breathing, and seizures. Okay, here's the downfall. Starvation of brain cells, right? Altered mental status, unconsciousness, and if left untreated, permanent brain damage. Now, what's interesting in my 10 years of being in EMS, it seems like the diabetic calls only occur from like 4 in the morning till like 8 a.m., right? And usually it's husband and wife or whatever, and they hear their spouse breathing funny, wakes them up, right? The guy normally snores like a freaking freight train, but now he's not snoring. So she wakes up, can't wake him up, calls 911, we're there. Or in the morning, they oversleep, they took too much insulin before bed, or whatever the case might be, and now they've got issues.
Probably do a lot of that. You don't want to leave.
Yeah, can't with the machine, they're lucky. It's going to hit on the next spin, I promise you. Hyperglycemic, right? Now, how often? You take a poll. Anybody encountered these people, hyperglycemic patients? A couple of us, right? A couple of patients in your career in comparison to the probably hundreds you see on the hypoglycemia side, right? It doesn't happen as often, but it definitely does happen, right? So here's what we're talking about. Your body can't use the insulin, therefore, it causes issues. Some of the causes: stress, increased dietary intake. Now, the signs of it, right? Over days or weeks, chronic thirst and hunger, increased urination, and nausea. Okay? Now, here's the downfalls: profound dehydration, excessive waste products released into the system, diabetic ketoacidosis. Now, if you've never heard that before, it sounds bad, which is equal to how bad it really is. Okay? Because what's the treatment in the field? You as an EMT, me as an advanced EMT, Sky as a paramedic. What's the treatment? It's all the same. We cannot give insulin pre-hospital. Right? So for us, start an IV given fluid. Everyone's like, well, you're diluting the sugar? No, we're treating the dehydration. Us pumping fluid in them does not dilute their sugar levels, right? We're just trying to treat the side effect of dehydration. On the diabetic ketoacidosis side, rapid breathing, right? What's the most common breathing pattern? Remember, we watched the video of it yesterday. Who swallows breathing? hanging out, sleep on the windowsill, and come down. Right, I like it. The other dead giveaway is this acetone odor on the breath, right? Fruity, acidy smelling breath. It can be coming out of their skin, coming out of their mouth. You can physically smell it. Okay? Put the video back in here. We are not playing. I'll probably get fired. But in this video, you can hear the doctor say, we note some acidy smelling breath as well. Okay? So onset, long time, okay, 4-10 hours for DKA, Kussmaul's breathing, thirst and dehydration, tachycardia, hypotension, acidosis. We're talking about a glucose of over 240, right? Which is why most of your glucometers, when you exceed 240, it will flash the number 240 and then flash the word ketone and then 240 and ketone to make you understand that it's likely they've got that ketone production in their body that can lead to acidosis. Okay? Now, I found this a couple months ago. This literally sums up it perfectly. Hot and dry is sugar high, cold and clammy needs some candy. Right? Hot and dry is hyperglycemic, cold and clammy is hypoglycemic. Summed up in a cartoon representation of that. I feel like EMT class, I should just teach this one slide. That's all you need to know. You successfully passed the NREMT. Okay? So Facebook gives you, I get this crap on Facebook. It's like 10% useful information. It's crazy. Everything has side effects, right? As increased acidosis, or as acidosis increases, we can get what's called metabolic acidosis. Well, that's bad. Now we're starting to give this to all parts of our body. pH level messes with your kidneys, your renal system, nausea, vomiting, diarrhea, cardiac disturbances. All those things then become problems. Shock, severe dehydration. So what are some safety considerations to worry about with these patients? Needles, right? Now here's the nice thing. Most, I'm not saying all, most diabetics, right? You walk into a scene and we build those scenarios. And you walk in, there's needles everywhere. Well, if the needles are capped and in a coffee can, they're probably diabetic. Drug users don't clean up their needles. Diabetics normally do, right? So like keep that in mind. They're usually really, really good about where they're putting those insulin needles, right? And they also don't really use the same needle over and over and then give it to their friend and they do their insulin and your friend, and that's just weird. Okay, what else? What are safety issues besides needles? They can be combative. Now, we talked a lot yesterday about body position and reasonable force. Our response is a lot different, right? The psych patient who attacks you versus the diabetic who takes a swing at you. Diabetic takes a swing at me, I'm not likely to like step in and ram onto the ground, right? You might have to get a handle on it, but the response is much different because you know they're altered. They don't know what they're physically doing. And you can argue it as a psych patient, but it's kind of different. Well, it's not your psych patients, it's usually the drug guy who wants to fight you. Okay? Patient assessment. How did it occur? How long ago? Any other symptoms? What was the mechanism? Think about your seizure or fall patient. Did they fall? They hit their head. We worry about C-spine. We worry about a back injury. Okay? If they're operating a motor vehicle and they crash and now they're unconscious, were they unconscious when they wrecked their car? Or did they wreck their car and now they're unconscious? Because we're talking about two different injury patterns there. Like we always talk about in class. Medicals can cause traumas and traumas can cause medicals. So make sure you don't get, that's why I don't like the skill sheets, is because it hooks you into one or the other, pick one. Well, why don't we just teach you how to work with humans and you determine is it medical or trauma or both. Device used in monitoring and treatment of diabetes. Some of these are really, really cool. This one's awesome. Non-invasive monitoring every 10 minutes up to 13 hours. Okay? This tells you your glucose every 10 minutes. And if I remember right, this device has its implant, there's something implanted, I think it's in your abdomen, that checks your glucose and gives feedback to this device. And I now know this is a little bit old technology because there's apps now you can have on your phone. It links right to your phone, and it just, your phone vibrates or alerts when your sugar is high, low, whatever the case might be. Okay? These are kind of cool, right? Our insulin pumps. When are these a problem? What do you think? What's that?
When they don't work.
When they don't work well, right? So let's say a patient presents unconscious, right? So you get there. Advanced EMT shows up, paramedic shows up, gives them D50. What's the problem with dextrose 50? Anybody know? It causes sugar increases in the hundreds. So we take your glucose from 10 and put it at 350. What does your pump do? Gives you insulin. And you go right back to the other side. And we're like, well, that's weird. Let's give them more D50. You give them D50. What does your pump do? Yeah. That's why you call medical control and say, hey, can I turn it off? And medical control goes, uh-huh. Right? Now, oral glucose, you don't raise their sugar that much to usually indicate a release of this. But let's say you don't have the oral glucose and you give the food, the drink, and you give too much. Your pump's going to kick in and go, gotta go lower. Okay, so assess for these. Where are they usually located? Midline, yeah, on a waistband, right? I have seen some of these. I saw a good the other day that it looks almost like a medication pack that's on their arm, but it's got a piece of plastic on it that is actually helping with that reading of that glucose. Okay, so ask questions. If you find a device you've never seen before, then ask about it. If you're searching down at their ankles and you see something like this, it's probably not a glucometer. Okay, like I met a kid, I like got his ankle bracelet. I said, "What's that?" He goes, "My GoPro." I was like, "That's the dumbest thing ever." No, I guess it does track everything you do, but not the way you're thinking. So insulin pumps, right? Goes in the skin like this. Continuous feedback. Be careful. These can come dislodged or get cold. If you're cutting clothes, God forbid you don't pay attention and you cut through a hose, or you don't look. You don't want to be damaging these. They're expensive. You don't know if your patient had to buy them out of pocket, insurance paid for. So be aware of that. When it's left at sea, make sure we don't leave it. Make sure we pick it up, bring it with us. That kind of thing. On the patient assessment side, really, you get their sample, get their OPRC, but start getting the diabetic. And I pretty much made it a rule of thumb. I ask my, do you have any medical conditions? And they say no. And I say, just confirming, you've never had a heart attack, you've never had a stroke, and you're not diabetic. Because I don't know how many times I've asked, do you have medical conditions? And they say no. When you get to the hospital, the doctor said, hey, how you been doing with your diabetes? They're like, oh, pretty well. And you're like, I don't. I asked you. And they're like, oh, yeah, I forgot. Oh, my God. Right? So I always ask them, are you diabetic? Right? And if they say no and you find a glucose that's low, I wouldn't be like, well, you're diabetic now, or you're pre-diabetic, or that's not our job. Right? Pre-diabetes is diet and exercise and A1C levels and all that stuff goes into pre-diabetic or high risk for diabetes or things along those lines. Glucose meters, we kind of talked about this already, but anything less than 60, and the key word here is that's symptomatic. Now, I'm sure we've all met diabetics who hang at like 58, and they're just good. That's okay, right? Now, there's the other side, which is that anything over 140, they consider to be hyperglycemic. Now, we talked about yesterday, I'm aware that we see these patients all the time. Normal at 180, 190, 200, 210, 300. And you ask them, and they say, well, that's my normal. Well, those are the patients that we see with amputated toes and legs and neuropathy and renal failure, because you're right, that's your norm, but you are constantly, literally poisoning your body and causing damage that can't be reversed. Now, you turn that glucometer on and you put the bloody end inside the glucometer, and it says high. Most glucometers will only read between 15 and 500. Anything over 500, it's going to flash high. It's rare that it flashes error when it comes to an actual reading. Error is almost always a battery problem, right? Low, never a good sign, right? And I've had those diabetics, you walk in there and they're unconscious snoring on the floor, and you go, let's check their glucose. And sure enough, it's like it counts down, 5, 4, 3, 2, 1, low. Knew it, and we go ahead and give them sugar, right? We had a guy in Deer Park, we used to transport all the time for diabetic, same presentation, every single time we'd go to his house, right? Transported him 5, 7, I don't think we transported out, that was below refusals, 5, 6, 7, 10 times, whatever. We walked in the door one time, I was an advanced EMT, walked in the door, started an IV, and we're working on a glucose, but I'm like, it's so-and-so, he's diabetic, right? So I start pushing the D50, give the whole amp a D50, as we finally get a glucose, right? The person looks at the glucose, and I've just given the D50, the person looks at the glucose and goes, it says 140. I was like, uh-oh. Like, okay, so it's multiple differential diagnosis idea. What else can cause? Sure enough, he got into his hydrocodone and took him to hydrocodone. Right? Checked his pupils are pinpoint. Like, frick. So now we give him Narcan, wake him up, and then we're like, hey, you also had an AMPA D50. So you may want to take some insulin. Sure, I rechecked his sugar was like 490. We're like, oh man, we're really sorry. Don't get complacent, right? It was my first encounter with differential diagnosis. My second was I transported a lady with stroke symptoms, activated a stroke, or recommended the activation of a stroke. We didn't have a medic, so we were in code to the hospital. 5 minutes from the hospital, I passed. The nurse said, what's the patient's glucose? I went, I didn't take it. Hung up the radio, checked his glucose, 17. It's like, oh no. Gave the glucose, all the symptoms, rolled in the ER, like, hey, stroke team, good to see you, bad news. Like that. That was all me. Good job, guys. It's a test. You did a really good job. You got here quick. Really sorry about the cost of that. Occasionally, one can treat a person, right? What are you guys doing? Like in backcountry, do you guys carry anything specific for this, or it's like give them something to eat? Or are you carrying a power gel? Like what? Gotcha. Yeah. And those are all real good alternatives. In fact, they're probably cheaper than most of them. If you're going to give something, make sure it's just not full of sugar, right? Like carbohydrates are important, things along those lines. You know, a good, I'm not saying like cake frosting and oral glucose. That's all good stuff. But longer term, give them something to eat. Now let their bodies, get something to eat. They can actually break down and kind of work through that and deal with that. This said never administer food or liquids to a patient at risk for aspiration. If they're unconscious, don't chip a peanut butter and jelly sandwich in their mouth and be like, just gum it until it works. Those things, get them awake enough that they can then eat something, and then we can start working through that process. Oral glucose, the critical criteria, got to have a history of diabetes. They have to be altered, have to be awake enough to swallow, right? Now, there's nothing about the glucose level in a protocol for oral glucose, because the indication is not their sugar level, it's the presentation you have and a diabetic. So if they're a diabetic and they're altered, they get sugar. Plain and simple. Unless you check their sugar and it says 900, which it wouldn't, it would just say high, then of course you're not going to give that oral glucose. Okay? But for the most part, if they're diabetic and they're altered, they get sugar. Okay? Squeeze it directly into their mouth. We can administer and use a tongue depressor to kind of help with that, decrease the risk of aspiration. Anybody do that? Or they just take the tube and go into their mouth, swallow it, right? I would try to give it like 4 pieces, a little bit, so you're not filling them out full of cake frosting or, gel or whatever that stuff. It tastes like crap. Now, I would be on board with the cake frosting because I feel like the taste would be a lot better than the glucose crap that we have. Reassess after administration. Condition doesn't improve, consult medical direction about whether or not to administer more. If you don't have medical direction, then give them more. Again, side by side, hypoglycemia versus hyperglycemia. Hypo, a slower onset, where it usually comes on, slower. Hyperglycemia or hypoglycemia is going to come on much faster. And then again, there's that hot and dry versus cold and clammy. Breath, again, that acetone, Kussmaul's breathing, that's really going to be associated more on the hyperglycemia side, and we really don't see that in the hypoglycemia side. Cool? Any questions on the diabetes? Really hope for a picture of Mac.